but there's still many exciting lectures going on. So next, we're going to the next plenary lecture, which will be moderated by Professor Professor In Wen Zhong. Please, Professor Zhong.
Thank you, distinguished guest, Professor Gary Wang, my co-chairs, Professor Andrew Collins, and Professor Zhengong Dai. Ladies and gentlemen, it's my great pleasure to introduce our next speakers. Professor Gary Wang obtained his undergraduate medical education from the University of Alberta, Canada. He subsequently received a fellowship training at University of British Columbia and Children's Hospital of British Columbia, and visiting fellowship at the Children's Hospital at Munich, Germany. He is the immediate past president of the Asia Pacific Academy of Pediatric Allergy, Respirology, and Immunology. Currently, he is the president of Hong Kong Institute of Allergies and one of the board of directors of the World Allergy Organizations. He is one of the steering committee members of the International Studies of Asthma and Allergies in Childhood Research Group. Among other duties within many education boards, he is also an associate editor of New England Journal of Medicine. Today, he is going to talk about how can we put an end to the COVID-19 pandemic. Ladies and gentlemen, please join me to welcome Professor Gary Wang. Professor Gary Wang, please.
Thank you very much for the organizer in giving me the opportunity to discuss with you this important topic, how to put an end to the COVID-19 pandemic. I think over the past 1.5 years since March 2020, when the COVID-19 outbreak was declared to become a pandemic, all of us have been asking this question many, many times over. And in order to figure out how we'll be able to put an end to the pandemic, we may want to look at the history over the past 100 years. Well, what exactly were responsible for pandemics in the last century? We can have a look here that 4 pandemics have all been related to influenza virus. The famous 1918 pandemic H1N1, followed with the 1957 H2N2, and the 1968 pandemic due to H3N2, and then the relatively mild 2009 pandemic due to H1N1. And in the last 20 years, there has been a couple of viruses that try to achieve the status of a pandemic. And they are the SARS in 2003, which is a novel coronavirus attacking humans, followed with the MERS in 2012. Primarily, the cases were limited in the Middle East. And there was also an outbreak in Korea. But these 2 viruses did not achieve the status of a pandemic virus. And there was also, in between the period of 2013 to 2016 of the Ebola outbreak, primarily the cases were in Central Africa. And when we look at these viruses that achieved the pandemic status, they were all due to influenza, and they all have some reassortment of viral genes from avian or swine influenza. Because of the reassortment resulting in a new strain, humans were not immune to this infection. And there's also a common phenomenon that these viruses succeed because they did not kill the host in most of the cases, such that there are many cases of mild infection, and the humans can bring the virus from one region to another region, from one person to many other persons, unlike SARS-CoV-1. And if one look at the famous Spanish flu, the pandemic in 1918, there were no vaccinations. There were no effective specific medications for influenza. The pandemic stopped. We basically back then tried to combat this infection by isolating the infected, cut down on the number of infection as much as possible by the use of masks, and eventually large percentage of the population became immune from natural infection, leading to the cessation of the pandemic. And if one look at the current scene due to SARS-CoV-2, one will realize that this pandemic is causing major problem currently, especially in the Americas, and also with the emergence of new variants such as the Delta variant with very high infectivity. Cases are surging across many European countries. And if one look back in the situation in late 2020 and early 2021 in the United States, the situation was very bad. And as a result, if one look at the typical Western approach at that time, the approach was trying to keep the economy open as much as possible, as long as there are not too many new cases that may overwhelm their hospital system and ICU, and also strict limitation and control of people in terms of shutting down are rather difficult in those countries. Instead, they put a great bet on developing effective vaccination. And in the US, they have the Operation Warp Speed with major seeding money to speed up vaccine development. And of course, vaccine is a very important tool to help to stop the pandemic. If one look at the famous disease smallpox, that has killed millions and millions of people. But how exactly do we make a vaccine? And the term vaccine comes from the Latin word vacca, meaning cow. And the vaccine that we use is the virus, vaccinia virus. And it was the careful observation of Dr. Edward Jenner, an English physician, who observed that milkmaid had very mild cowpox infection. And with that, they are immune to the development of smallpox. And in fact, if one look back at the history of this vaccine, the natural infection, as you can see here with a pair of brothers, the one on the left was infected because he was not vaccinated, while the other one was vaccinated and protected from infection. And this infection can have a mortality, particularly in young infants, up to 80%. And if one look at the deaths related to smallpox, in the 20th century alone, it was estimated as 300 to 500 million people died from this infection. And when the virus was brought to the Americas by the Europeans, it basically killed off 90 to 95% of the natives. And with the development of vaccination and widespread use of vaccination in stopping outbreaks, the disease finally was eradicated from the human being, and it was declared eradication by the WHO in December 1979. And in fact, if one look at the history of using some sort of infection resulting in protection, one will realize 291 years before Jenner's work on cowpox, a Chinese doctor in the Ming Dynasty from Hubei, in fact, they have this method of getting scrapings of dry powder smallpox scabs from infected individual and use a very long tube and blow it up the nose. Basically, the recipient would develop a very mild disease. But with this method, there was a mortality of 0.5 to 2%. So it's not exactly benign. But this was replaced by the widespread use of the vaccinia virus, the smallpox vaccine, subsequently. And if one look at how the immune system learned to recognize and respond to various antigens, and usually when we get exposed the first time with some sort of antigen with a primary response, and within a few weeks, if we give another dose of the antigen, that tends to bring a secondary response, which result in a higher peak of immune response to a particular agent. So in the last year, we have seen rapid development of different type of vaccines. So are they going to help us to end the pandemic? Now we have the messenger RNA vaccine from Pfizer and Moderna. We have the adenovirus vector vaccine from the AstraZeneca Oxford group. And we have the inactivated virus from mainland China. And we have also the subunit virus, vaccine Novavax. Well, how exactly do we make the vaccine? Well, there are different strategies. One can use live but attenuated organism, such as polio, the Sabin vaccine, MMR vaccine. But not all infective agents can be easily attenuated. So another way is to inactivate, kill the virus, such as the use of formaldehyde in inactivating the polio vaccine, the Salk vaccine. And they're also using parts of the virus, such as the hepatitis B surface antigen, using as a subunit vaccine. So, but when you develop these sort of vaccine, you're going to need a lot of antigen, a lot of that virus, and you have to cultivate these viruses in live cells, such as the influenza, using the eggs. So we have newer ways of making the vaccine when we understand the pathophysiology of SARS-CoV-2. Well, we know the spike protein is very important for attachment to the ACE2 receptor on respiratory epithelium. Once attachment takes place, the virus is internalized and causes infection. So if one can stimulate the immune system in making antibody against the spike protein, that would be highly efficacious. Well, so can we teach the cell, all right, give some instruction and teach the cells to stimulate the immune system? And that's the basis of the DNA vaccine or the RNA vaccine. The DNA by giving the DNA material that gets into the host cells and cause expression of a certain part of the virus on the surface membrane. An RNA is basically an RNA encoded specific instruction. In the case of the COVID-19 vaccine, it codes for the spike protein, and it's packaged in a nanoparticle and get internalized by various cells and expressed on the cell surface, stimulating the immune system to produce an immune response. And with that, the rapid development goes through animal study, as you can see here in this DNA vaccine against the SARS-CoV-2 in animals. And subsequently, there are this phase 2 trial of the Moderna published in the New England Journal showing very effective, stimulating a very effective immune response producing antibody against the spike protein. Subsequently, with large phase 3 trial, the vaccine efficacy was demonstrated. And this is the way we determine the vaccine efficacy. Of course, if there were lots of cases circulating in the community, it would be relatively easy to demonstrate whether the vaccine works or not. And also, the better vaccine, the fewer the cases that would be needed to detect protective ability, because there would be a large differences between the vaccinated and the placebo group. But we can only look at specific time interval. Okay? For example, the current vaccines we have for SARS-CoV-2, basically, we have data on the efficacy over a period of time of something like 3 months. So we also need to remember the virus can mutate. And when they mutate, it may affect vaccine efficacy. And one look at the Moderna virus, one of the messenger RNA virus. You can see here the phase 3 trial published in the New England Journal of Medicine. You can see comparing the placebo group and the vaccinated group. There's wide separation. And one calculate out the vaccine, Moderna vaccine efficacy, and this is how we calculate it. So among the almost more than 15,000 who were vaccinated with the placebo, there were 90 infections. While the 15,000 who were vaccinated with the active vaccine, 5 of them developed the infection. So with that, one can estimate the vaccine efficacy was 94.4%. But one must remember, now from this trial and the data, out of the 15,000 who got placebo injection, 99.4% of them did not get infected. So that means if one calculate the number needed to treat for saving one person from infection, we're talking about a number something like 179. But of course, these numbers may change depending on how severe is the outbreak of the infection in the community. But in any case, a lot of people who may not get infected or who may get infected developing very mild infection, we need safety of the vaccination. And when it comes to safety, it takes a large number, in particular, if we want to detect rare infection or rare side effects. And also, the longer the trial, that is, the follow-up period, the more likely we may be able to detect appreciable delayed side effects, if there are any. So for example, if one look at the adverse effect of the Oxford AstraZeneca vaccine, the Johnson & Johnson vaccine has a similar problem because both of them were adenovirus vector vaccine. And they were shortly after this vaccine were authorized for emergency use, there were rare reports of CNS thrombotic event. And this event commonly occurs in young women. And the estimated incidence in the group that is at highest risk are the 30 to 39-year-old women, estimated to be about 1 in 100,000. And subsequent careful investigation of these patients, it appears that the vaccine can stimulate the body to produce a presence of specific antibody, the platelet 4 antibodies, which result in the problem of clotting and thrombocytopenia and the central cerebral venous thrombosis. Now, one must remember the typical vaccine schedule, actually from preclinical to clinical, going through the different stages, and regulatory review. Very often, it takes about 6 to 8 years minimum. For the SARS-CoV-2 vaccine, we have only spent about a year and a half. And when it comes to vaccination, I'm sure many of you have seen these numbers being quoted. So some being higher and some being lower. But one must remember, these trials were done at different period of time with different type of variants circulating and also in different populations. So it's not fair to compare these numbers directly. But when you come to the vaccination, we should look at what exactly do we try to prevent. Do we try to prevent all infections? Or do we want to turn symptomatic infection into asymptomatic infection? And actually, with vaccination, what we really want to prevent are those with severe symptoms. Prevent people from getting sick, resulting in ICU or death. And basically, all the licensed COVID-19 vaccine can achieve more than 90% in terms of protection against the severe outcome. And those are the outcomes that we care about, particularly. So when one look at the Eastern approach, in contrast with the Western approach, putting a lot of resources in developing the vaccine, the aim of the Eastern approach, such as in places like Korea, Taiwan, Vietnam, Singapore, Hong Kong, or mainland China, okay, these countries aims to contain and eliminate the virus from circulating in the community. So very early on, there was universal masking to cut down on the spread. There was very strict lockdown, very strict, Wuhan style. Basically, all the activity comes to a halt. And in terms of isolation, as opposed to the home isolation in many European countries and North American countries, in Asian countries, primarily institutional isolation. Because in many of the crowded cities in Asia, home isolation simply is not practical. And in January in 2020, when there was this massive lockdown in Wuhan and Hubei, there were a lot of criticism from the Western media, as in this case, a story from Washington Post expert from the United States criticizing these sort of unprecedented quarantine of big city would not work and never effective. Well, that was the criticism. But at the end, if you look at, from Wuhan to Taiwan and all the cities and countries in between, Italy, Spain, France, UK, and then to North America, to Rio, and then Taiwan. Basically, all the countries would use similar strategies of lockdown. And subsequently, there were no more criticism. In fact, people were trying to balance how tight the lockdown should be in different countries. And there were some modeling determination of how effective of the lockdown was in Wuhan. And as this analysis published in Science last year demonstrate, the lockdown in Wuhan indeed reduced the number of infected cases dramatically in mainland China. And of course, it would reduce the number of deaths dramatically. Well, the Eastern approach has been to end the pandemic by containing it, by eliminating it, hopefully, just like what had happened in 2003 with the SARS-CoV-1. But this time around, because of the presence of lots of asymptomatic or mildly symptomatic people, it's much more difficult to achieve, particularly in other countries who may not be using the dramatic public health measures that were used in many Asian countries. If you look at the use of masks, there were lots of demonstration or arguments or problem in Europe that people would like to have their own freedom. They don't want the mask. Lockdown, they don't want that either. They want to have their personal freedom to go around. And in terms of testing and isolation, there was massive problem in many countries in terms of the capability of doing testing. And I mentioned earlier, the use of home isolation in many Western countries has been found to be highly ineffective, while institutional isolation is more the norm in Asian countries. And when it comes to about the discussion of testing, I think this example show how massive, dramatic scale of testing can be. A couple of cases of the port workers in Qingdao late last year, with routine testing, they were found to have asymptomatic infection. And those 2 port workers were taken to a local hospital, the Qingdao Chest Hospital, which was designated as the hospital to look after patients with COVID-19. And subsequently, there were a taxi driver who developed a transient ischemic attack and was investigated in Qingdao Chest Hospital. And he was found to have the infection. And with the infection, now because of the taxi driver, and also there was also 1 patient and 1 nursing assistant also found to be infected, all from the hospital. The Qingdao City decided to perform a total population of Qingdao population with testing within 5 days. There were 9 additional cases found, and they were all related to the cluster within the hospital. It's highly likely that the 2 port workers who were investigated earlier there spread to the other patients in this hospital, resulting in the nursing staff got infected, and the nursing staff passed the virus to the taxi driver. And that's how the outbreak was controlled. And during the 5 days of the testing in the city, there were no specific lockdown, so to say, for the people. People were not allowed to use public transport until they were test negative. And if people leave Qingdao, they need to have a negative test, and also they have to be home isolated for another week and retested to make sure they're not infected. Now imagine, because in countries where a lot of people are not vaccinated and a lot of people are not immune, a few cases would result in a significant outbreak. But of course, these sorts of testing required a lot of cooperation from people. Imagine, testing 10 million people in 5 days. You need not only the laboratory facilities, you also need the cooperation of the citizens. And if one wants to look at the results of how well different countries control the outbreak, I think probably the best statistic is to look at the number of deaths per 100,000 population. This data coming from the Johns Hopkins University monitoring. As you can see, a lot of the countries with very high mortality are usually European countries or in America. Okay. Now, up to, for example, the data I have shown you here with the bold black letters are those as of August 26. In Hungary, it's 312 per 100,000. In UK and USA, it's 200 per 100,000. But what about Asian countries? Well, if you look at some of the Asian countries, look at Japan, about 12.5 per 100,000. Thailand, 14.06. Indonesia, 47. Vietnam, 9. And then Korea, Singapore, China. You see the numbers are very, very low. And if you look at the current as of August the 26th, the rate, the mortality in Italy is 237 times that in Singapore. So certainly, for now, many of the Asian countries have done much better than that of the European countries. But as long as the virus are circulating in some parts of the world, Asian countries can be very vulnerable to various types of infection. For example, like the current Delta variant. And if one look at the projected COVID-19 vaccine coverage around the world, well, by the end of this year or early next year, yes, we can see in North American country and Western European country, and for Asia, probably with the exception of Singapore and Hong Kong, the vast majority of the countries in Africa, Southeast Asia, and also across the Middle East, we will be far from reaching a state of herd immunity. So that means as long as there are pockets of places where there are active circulation and infection, who knows, some other new variants may develop. Currently, our current vaccine seems to be still effective against the Delta variant in terms of severe disease. But certainly, we're seeing they are not as effective for preventing infection as in the original variant. So that means, no matter how we protect our border, we cannot shut down our border forever. And so we need to watch out. And if one look at the various emerging respiratory virus over the last 20-odd years, you can see, the new in the avian influenza. We have been lucky that the transmission of avian influenza is rather difficult from one person to another. You need very close contact in order to catch infection. As a result, we've been lucky that the various avian influenza did not result in widespread transmission. But who knows what will happen in the future? There is various viruses emerge and in the human population. Now we have the COVID-19, and I'm sure this will not be the last virus. The next virus will come. It's a matter of time. So we need to be prepared. Now, if one look at the 4 pandemics in the last 100 years, there are things that are in common. They have a lot of relatively mild patients, right? And they can spread easily from one person to another one. The coronavirus has similar characteristics. Flu vaccine was developed The first one was commercialized in 1945. So from 1957 onward, the pandemic, in a way, were kind of controlled with the help of the vaccination. But still, you can see the two pandemic, 1957, 1968, there were millions of deaths. And now the coronavirus has caused more than 4 million deaths around the world already. So when you think about how to put an end to a pandemic, do we want to eliminate the virus from human transmission, such as what we've done for SARS-CoV-1? But it was relatively easy for SARS-CoV-1 because when a patient can transmit the virus, usually the patient is symptomatic. So it's very easy. We can diagnose the patient, isolate the patient, and then we can stop the chain of circulation. SARS-CoV-2, the story is totally different. There were so many asymptomatic patients or mildly symptomatic, such as the virus, who continue to propagate in humans. And looks like we'll have to wait until most people became immune, either by infection or by vaccination. Do we see the end to this pandemic? In the meantime, various measures, right, should be used to minimize transmission, particularly to the at-risk group. And there's actually a choice how we want to do it. Right? If we do stick to, very strict public health measures, right? Because whatever we do, there will be a price tag. There will be a cost. If we lock down, shut down the economy, there will be a cost. But there will be a lot of lives saved too, as demonstrated by the first wave of outbreak in many Asian countries. And at the end, the combination of public health measures, the massive use of testing, the use of masks, and the behavior of social distancing, and the limitation of personal freedom, they all help to end the pandemic. And of course, with effective vaccination, that would help us to speed up to reach the end of the pandemic. And hopefully, we'll learn from all the what had happened with the 4 pandemic due to influenza and the pandemic due to coronavirus, SARS-CoV-2, that we will do better when the next virus comes around. And I thank you very much for your attention.
Gary, hi, this is Andrew Collin. I am in charge of the Q&A for you. Very nice to see you from
Good
the other
evening,
side of the world. Can you hear me?
Yes, very well.
Hi. Well, there are comments, of course, of the wonderful talk, which an opinion that I, of course, share, not surprised. And I really appreciate the depth and detail of your approach here. There are some questions that I will share with you. I'm not sure that we'll be able to go through all of them. One question is about considering poverty and environment. Would you recommend a policy of COVID-19 vaccination for children at different age groups?
Yeah, Andrew, I think we are seeing accumulated evidence that children do play a significant role in spreading the infection. There were outbreaks in school, and then within the outbreak, the teachers got infected. And I personally don't really worry too much about children. A small minority of children develop, for example, most severe complication related to COVID-19, multi-system inflammatories. And yet, even if you look at that rare complications, the mortality is extremely low. US data suggests that it's something like 1 to 2%. And our way of treating immune response related to system inflammatory syndrome. So I would expect nowadays when we treat the child with that syndrome, our success will be a little bit better than the original data published. But the fact is, we have to get the children. Otherwise, they would continue to spread the virus in school and spread to the adults. And we know now, even if we're infected or if we get immune by vaccination, the coronavirus, for some reason, our immunity do not sustain. After a while, after a natural infection or vaccination, our immune protective capability drops with time. So it looks like as long as there are viral circulation, we will be needing regular booster of immunity of vaccine every now and then, so that regular vaccination for children be an important part of combating this infection. Unfortunately, if I always say, if all countries in the world can behave like many of the Asian countries in the initial wave, we could have eliminated this virus from human circulation. But given the picture that we're seeing right now, I think we can achieve that. Once the border of many of the Asian countries open, the new variants will come in and cause trouble. So we just have to live with this virus.
Different angle is asked here about the possibility of targeting the expression of ACE for prevention or treating childhood COVID-19. Is there such an approach at all that is dissociated from the question of vaccination?
Yeah, if one look at data related to ACE2 receptor, as well as the severity, yes, there seems to be data suggesting, for example, in the patients with asthma or allergic disease, the expression seems to be a little bit lower. And also, in general, children's expression appear to be a bit lower. But I would hate to use that strategy to manipulate, the density or the ACE receptor, because, we don't really understand the biological function. The ACE2 receptor are there for a specific physiologic reason. I would think that approach of trying to manipulate ACE2 receptor, at least on a population level, would be dangerous. In patients who are infected, maybe, but and also we know those who develop severe disease, it's not just their attachment, it's their subsequent immune response to the viral infection. So the current strategy managing those severe cases really is immune manipulation rather than targeting the entry of the virus. The entry of the virus through the ACE is more for preventing infection.
Another question here along the lines of antibody creation is there are opinions that the antibody for COVID-19 is not a reliable marker of protection. And I think that actually this resounded strongly in the opinion that was heard at the FDA the other day, where I think Dr. Gandhi stated that, you have type B type and T cells that are active despite the fact that the titers are not elevated. How does one approach this in the future?
Yeah, the current approach of trying to test whether someone is immune or not very often is look at the antibody against the spike protein. But that is only, to me, it's a one specific part of our immune system in protecting us. And certainly, purely just measuring the antibody may not be at all a reflection of the immunity. And the other cellular immunity, mind you, measuring cellular immune response are a lot more complicated than measuring antibody. Currently, I don't see a good way of how to get around with this other than a population approach. If, let's say, if the majority of the community vaccinated, majority of them, and when you, for example, measure antibody, many of the people, you can at least detect antibody. One would tend to suggest, at least in this community, it's reasonably well protected. In particular, just like the flu, we want to protect in flu, we want to protect disease and severe complication in the two end of the spectrum, the very young and the very old. I think for SARS-CoV-2, slightly easier. Even for the very young one, we know from data of infection in the neonates and infants, they don't get very sick at all. So it seems, if we get those, for example, those with comorbidity, those over 60 years of age, if we can get that group well protected, the coronavirus, the SARS-CoV-2 will become another flu virus that we have to live with daily basis.
So another angle to the same question is relating to the statements by Professor Verinder Singh yesterday, who was talking about comorbidities. And so would one take a different approach in protecting the children with comorbidities? And particularly the question relates to Asia. I'm not sure why in Asia it would be any different, but that's the nature of the question.
It's interesting, despite the fact that we worry about comorbid conditions making COVID-19 infection more severe. If one look at the mortality data among children, excluding those related to multi-inflammatory system syndrome, in fact, there have very few deaths related, to children with comorbid condition and COVID-19. And even if one look at the population, asthma, probably most common respiratory disease children. And yet there are all sorts of data suggest, except for the very severe spectrum, poorly controlled asthmatic. In general, asthmatic are not at a very high risk of developing severe COVID-19. So in children per se, I do not worry too much about COVID. It's more the elderly that I worry. And that's probably the reason why in many countries, for example, in the UK and the US, they were starting vaccinating the third dose for that particular population.
I don't know whether there's a timekeeper, but can we go on, continue? Because there are other questions here. Is somebody keeping check of time? Dr. Zheng Kong Dai?
Yes, I think 1 more minute.
1 more minute. Okay.
1 more minute. Yes, please.
All right.
Thank you.
So this is another angle of the question of ACE2. Since the expression of ACE2 is closely related to pulmonary hypertension, are there any altered histologic changes in lungs of children who are infected, and I guess that people who die with COVID-19?
Very, very good question. I think there are very few pathologic reports because there are simply very few deaths. The deaths that I know of, for example, Asia, there was from the Wuhan cohort. One was related to a patient with leukemia, and another patient was a young infant also developed interception and a delay in management interception. But if you look at the path report, overseas, there may be a few also related to deaths related to system inflammatory syndrome. But I'm not aware of hypertension per se is a problem in terms of the pathologic from the lungs. Not that I'm aware. And one thing I would like to get back
Gary, I'm sorry, we're not hearing you.
Right.
So
Someone mute me. Now,
Yeah.
I guess mute everybody. Yeah. About the use of vaccination. Now, a lot of parents worry about two doses, particularly the mRNA vaccine. And because there are a very small percentage, something like 12 per million children, particular for the adolescent boy developing a mild form of myocarditis simply because of the most significant immune response. And there were discussion about why don't we just give them one shot. And I must say, giving one shot has not been tested properly in terms of its protection. And that's why, I see Andrew nodding. In the United States, you still give 2 shots to the adolescent, even though people are talking about shot. Because to me, I say, whatever you do in the pandemic, such as vaccination, on one hand, you want to achieve effectiveness. On the other hand, you want to minimize adverse effect. And the adverse effect, as we can see for the mRNA vaccine, yes, a mild form of myocarditis does happen. But if we cut out the dose, basically we give the primary stimulation without another secondary stimulation, without properly test this sort of regime, we don't know whether it's effective or not. That's why, in fact, in Israel, back in May or June, they have considered giving one shot to the adolescent. But at the end, when they look at the data, they decide not to do so.
Well, Gary, there are other comments about your wonderful talk, and thank you very much for it. And I definitely share that and look forward to see you in other environments. And thank you, everybody, for sharing with me. And we'll see you later. Bye-bye.
And thank you very much.
Thank you.
Good to see you all. Bye now.